afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on cannabis and pregnancy. My name is Dr. Sarah Carsley, and I'm the Applied Public Health Science Specialist in Healthy Growth and Development at PHO. I have the pleasure of moderating today's session. Before we start with today's presentation, I'll mention a few housekeeping items. Zoom allows attendees to have the ability to customize your own view. You can do so in the right-hand corner of your screen. Please use the Q&A pod if you have any questions during the session. We will save questions until the end of the presentation. The chat pod has been disabled to limit any distractions. If at any point during the session you experience any technical issues, please email events@oahpp.ca. I would like to state that as the moderator of this session, I do not have any potential conflicts of interest to declare. It's now my pleasure to introduce the speakers for today's presentation, Dr. Daniel Corsi and Dr. Mark Walker. Dr. Daniel Corsi is an assistant professor at the University of Ottawa in the Department of Obstetrics and Gynecology and in the School of Epidemiology and Public Health. He is a perinatal epidemiologist with content and methodological expertise in the areas of substance use and environmental exposures in pregnancy, social disadvantage, and epidemiological designs to improve causal inference. Dr. Mark Walker is a high-risk obstetrician and clinical epidemiologist. He is highly involved in public policy at the provincial and national levels, advocating for women and child's health, making a significant impact in the understanding of folic acid in pregnancy and thrombophilia in pregnancy. His leadership roles include being the scientific director of Born Ontario and co-lead of Safer Birth, a new initiative launched by the Provincial Council for Maternal and Child Health to improve quality and maternity care throughout Ontario. Dr. Walker is a former chair of the Department of Obstetrics and Gynecology at the University of Ottawa and former chief of the Department of Obstetrics, Gynecology and Newborn Care at the Ottawa Hospital. He is currently the interim vice dean of internationalization and global health at the University of Ottawa. Thank you both so much for being here today, and I'm going to pass it on to Dr. Walker.
Great, thanks very much, Sarah. I'm going to leave the video off just because my internet connection is stable right now and I want to keep it that way. I just want to thank Public Health Ontario and you, Sarah, for giving us this opportunity to speak on a subject that Daniel and I are both very passionate about, to one, do important research on the safety or harm, and also to really get the message out there of some of the findings that we have so far in our research. The next slide, please. So usual disclaimer, this document was created by its author and or external organization. It's been published on the Public Health Ontario website for public use as outlined in our website terms of use. PHO is not the owner of this content. Any application or use of this information in this document is the responsibility of the user. PHO assumes no liability resulting from any such application or use. Important disclosures, neither Daniel or I have received any financial support or in-kind support from commercial sponsors. None of the presenters have a conflict of interest to declare. So the learning objectives, really three things. After this session, participants should be able to describe the effects of cannabis on pregnancy and pregnancy outcomes, provide pregnant women and people with evidence-based messaging about cannabis use during pregnancy, and summarize current evidence on trends in use and safety in pregnancy. So what's the big deal with the effects of cannabis use during pregnancy? So in the American Journal of Obstetrics and Gynecology in 2015, a survey demonstrated that approximately 70% of both pregnant and non-pregnant women and people believe there is slight or no risk of harm from using marijuana once or twice a week. Next slide. And the general feeling is, it's a natural substance, it's organic, it's not synthesized, it's vegan. And there's no question that cannabinoids help with nausea, and that's been used in other areas of medicine, particularly in chemotherapy. And This is an example of a typical Google search, and this is what came up looking at medical marijuana and safety in pregnancy. And this is promoted by one of the companies, and it says medical marijuana is an entirely different factor that researchers have tried to study for many years. Marijuana is simply a plant cultivated for hundreds of years, even with hybrid varieties grown every day. Medical marijuana is not laced with any drugs or chemicals, unlike harmful cigarettes or alcohol. Should you use cannabis during pregnancy? Negative stigma and skewed results in unrelated experiments often scare people away from the benefits of medical marijuana during pregnancy. And as a provider of care to pregnant women and people, most get their information from the internet and from friends, not from their providers. So this is an example of what they could find when it's Googled. Next slide, please. So I'm going to shift gears here a little bit to some of the basic science, some of the physiology and embryology. And this is really, really important to our talk. The prenatal period is unique, and we go from one cell as an embryo, or two gametes to an embryo, to 70 billion cells. And the critical period of that actually starts from preconception and during pregnancy and onwards. And various epochs during growth and development have sensitivities to foreign substances. And it was years before we knew about fetal alcohol syndrome, where the dangers of it for the developing fetus was discovered. And in fact, not that long ago, when I was training as a medical student, we used to actually prescribe alcohol intravenous for pregnant individuals who had preterm labor. But we've found since that it has substantive teratogenicity, and exposure to agents that are relatively harmless to the mother may have adverse effects on the developing fetus. And all aspects of the central nervous system is vulnerable to injury from fetal exposure. Maybe not structural, but more functional in the way that the neurotransmitters and neurons form connections. And it may not be evident at birth either, but later to growth and development. Next slide, please. So cannabis is the most common used illicit drug in pregnancy, with prevalence rates between 3 and 25% in Western countries, often used with tobacco. And greater than 30% of individuals with FASD are also exposed to cannabis. So cannabis has a complex relationship with other substances and polyuse. Next slide. Then the potential deleterious effects of cannabis consumption for fertility and pregnancy outcome have been recognized for years. Delta THC is able to cross the placenta and accumulates in fetal tissue and in maternal milk. So why is that important? Well, the endocannabinoid system in pregnancy, there are 10 times as many receptors for the endocannabinoid than there are for alcohol. So they're very prevalent in the developing fetus, and particularly in the brain. And ECSS deregulation is associated with adverse pregnancy outcomes, including miscarriage and compromised placentation. Cannabinoids, including delta THC, CBD, and other metabolic byproducts, they cross the placenta and rapidly distribute to fetal tissues, including the brain. Next slide. And THC is measurable in fetal plasma within 15 minutes of maternal exposure, and it equilibrates to maternal levels in 3 hours. Has a long half-life, deposits in fatty tissues, and has low fetal clearance as well. Fetal exposure is prolonged even after maternal discontinuation. So there's the potential for it to be bioconcentrated in the fetus. Next slide, please. In teratogenicity, they're critical periods. The first 8 weeks is the one that we worry about the most, because that's when all the organs are forming, and particularly for drug exposures, that's pharmaceutical. If they have teratogenicity, it's usually during this period. In diabetics, we worry mostly about glucose control during the first trimester and its effect on teratogenicity. But equally important is exposure with fetal brain growth and development is in the second and third trimesters when the neurons are forming their complex synapses and interactions. So the potential for teratogenicity, particularly with delta THC and cannabinoids, is really throughout all of gestation. Next slide, please. In the periods that are particularly vulnerable, this is just looking at both the in utero period and after birth, the sensory pathways develop in the first couple of years, followed by language in 7, 8, 9, and then the higher cognitive function in the teen years. And certainly there have been lots of publications that have looked at the association between teenage use of cannabis and the later development of schizophrenia. And there's the potential of a double hit. So the first hit happens prenatally to the endogenous endocannabinoid signaling system when the fetus is exposed to cannabinoids. This could affect epigenetics as well as neurodevelopment. And the second is postnatally if the child is exposed to environmental stressors, nutrition, and possibly secondhand smoke and cannabis. Next slide. So where are we right now with research on the safety of cannabis during pregnancy? And really that's what provoked Daniel and I to look at this in a much more methodologic and using better databases and strength, because there's substantive limitations to the current research. It's very difficult to control for concurrent maternal tobacco smoking, as mentioned earlier. Cannabis is often used with tobacco. There are complex interactions with other substances, and it's difficult to just, when you're doing the research, to find cannabis only exposed without other substances. There's the association with social determinants of health that are hard to quantify in these populations. There's other prenatal and postnatal factors are important. The THC levels in cannabis are not standardized, and no one has measured how often, how exposed, and even the trimester of pregnancy of exposure to look at its impact. Self-reported data, which most of what's available has limitations. You don't know the quantity, you don't have a serum sample, the timing of exposure, and then there's underreporting as well. RCTs would be likely unethical, and animal models often don't show the whole picture. Next slide. So this is particularly relevant in Canada and many jurisdictions in the States, as the decriminalization first, and then the legalization of cannabis. So in October 2017, the government of Canada introduced legislation to permit the consumption, sale, and distribution of cannabis. In 2018, new legislation came into effect. And in October of 2020, there's over 1,000 licensed dispensaries. There's several large cannabis companies, and it was a bit of a gold rush in the stock market when they first came out. Next slide, please. Here's looking at the United States and places where cannabis is legalized. It looks very much like the electoral map, except instead of blue and red, it's blue and green. And then the states where it's legal for medical use, and the gray areas where it's illegal for any use. And that's only 2 states at the moment. Next slide.
Daniel Corsi here. Thanks again for the opportunity to present. So I'll be presenting results from 3 of the research questions that we've addressed so far. And the first is, what are the trends and correlates of perinatal cannabis use in Canada and specifically Ontario? And the second, what are the associations between cannabis use and adverse perinatal and neonatal outcomes? And finally, are there differences in neurodevelopmental outcomes in children born to mothers with and without cannabis use in pregnancy? So for this research, we use the Born Ontario birth registry. So Born is a prescribed registry, and that means under provincial legislation, it has the authority to collect and use and disclose personal health information for the purpose of improving provision of healthcare. And Born is the largest such registry in Canada, and it's one of the largest globally, in fact, and most comprehensive. So data are collected from various sources, including healthcare providers, hospitals, and birth centers, so covering a full range of care organizations. When pregnant individuals access care for prenatal visits and in the postnatal period. The data include maternal demographics, health behaviors, pre-existing health conditions, prenatal screening, obstetric and intrapartum outcomes, and birth outcomes, along with newborn screening data. So an ongoing program of data quality it happens at Born, and to assure a high level of data quality, and this has been going on for many years. So this is one of the most comprehensive resources for perinatal studies. And currently there's over 1.3 million maternal infant records that's been registered and Born since 2012. And we had identified for the initial research we've done so far over 10,000 pregnant individuals who reported using cannabis, making this one of the largest databases on prenatal cannabis use. So in the first paper that we've looked at, we started a series of papers beginning with this one on the trends in cannabis use and relationship with demographic and socioeconomic characteristics. And this is a slide showing a data set from Born. So we used Born Ontario first that occurred between April 1st, 2012 and December 31st, 2017. And some records were excluded due to missing data, just a small proportion, and for mothers outside of the 15 to 50 years of age. So the final cohort size was 732,018. And the objective for the study was to look at trends in cannabis use. And as Mark mentioned, we kind of interested around the legalization aspect and how the trends may be changing since then in the lead up to 2017. And the outcome in this case was self-reported use. Born collects data on substance use in pregnancy during prenatal visits, and that includes cannabis or other drugs such as cocaine and opioids. So an overview of the cohort, about 1.5% of pregnancies overall reported cannabis use, and that's equal to 10,731 individuals. About 70% are located in urban parts of the province, and more than half, 55%, are in the lowest two income quintiles, so more socioeconomic disadvantage. And among individuals who reported alcohol and tobacco use, rates of cannabis was 12 and 10%. So it's substantially higher among individuals who use other substances. And over time, the age distribution of cannabis users has shifted. So in the first year of data, 60% were aged 15 to 24. And then this sort of declined somewhat over time as the rates of use increased among other ages. So this is, I'll show you, this slide shows the data in a different way. The prevalence of cannabis use increased across all age groups, although it started from different levels. So again, the 15 to 24 years are the youngest groups, had a prevalence around 5%, increasing to over 6% in 2017, whereas the remaining groups were around 1% or lower in 2012. But for example, for 25 to 29 years, the prevalence roughly doubled from 1% to 2% over the study period, and it increased among older ages as well. So we're actually updating some of the data. Some of our findings are available at the link below at the Born Ontario website. But we're working to extend the trends out beyond 2018 now, because there's more data available in the post legalization period. They've also separated the younger group into 15 to 19 years of age as well. And interestingly, this group has prevalence over 10% by 2016, although it may be somewhat stabilizing, but we have to continue to see the more recent years of data, what's happening. Okay. So we also found increases over time in across income groups, although the rate of increase was somewhat greater in the lowest 2 income quintiles. And again, I've just also shown this separately with another additional year of data. And this is a bit easier to see that in the lowest income quintile, that the slope is somewhat steeper. So the rate of change is faster compared to the higher income group. This is based on area level income. Okay, in our second paper, we show the association between cannabis use in pregnancy and birth outcomes. So as a similar cohort, it's also using Born Ontario. We have births between April 2012 and December 2017. There is some additional exclusions in this cohort due to different outcomes in covariate selection. The final cohort was just over 660,000 pregnancies. Our exposure is maternal reported cannabis use. The primary outcome was preterm birth, and we had a number of secondary outcomes, including small for gestational age at birth, placental abruption, stillbirth, and maternal outcomes, including preeclampsia, gestational diabetes, and neonatal outcomes for transfer to neonatal intensive care and APGAR score. So we used here a matching design. This helps address some of the confounding and differences in the socioeconomic characteristics. I'll describe that in detail in the next slide. But overall in the cohort, there was 9,427 individuals with cannabis use. That's 1.4% prevalence. The mean age of the pregnant individuals was 30 years. In the infants, the mean gestational age was 39 weeks, and 51% were male. Okay, so this is the table 1, which shows the unmatched and the matched cohort. So to account for the specific demographic characteristics associated with cannabis use, which we showed previously, including age and socioeconomic status, tobacco and alcohol use, we use a matching procedure. And this essentially subsets the data such that we're within each band of age and income, we're comparing individuals with the same age and grouping them just by cannabis use. So we're essentially removing the effect of some of the potential confounders to isolate the cannabis association with outcomes. And in the matched cohort, as you can see, we reduced the sample size substantially, but we still had 5,600 roughly individuals with cannabis use, and 92,873 without use. So, but we achieve more balance in terms of age and other socioeconomic characteristics, and particularly substance use, such as tobacco, alcohol, opioid use in pregnancy. There's some of the results from our match sample. So again, the primary outcome was preterm birth, which is birth occurring before 37 weeks of gestation. And among cannabis users, the rate of preterm birth was roughly 3% higher compared to non-users. And this is 1.75% higher for preterm birth 34 to 36 weeks, and sort of in the area of 0.5% higher in the earlier preterm births, although these deliveries at these gestational ages are less frequent, so the estimates are smaller. And again, so we use the matching that includes the characteristics mentioned here, and that's from the previous slide as well. In terms of secondary outcomes for small for gestational age, placental abruption, stillbirth, and NICU, there was some differences here as well. Small for gestational age at the 3rd percentile was roughly 2% more common among cannabis users, and nearly 5% more common for SGA less than the 10th percentile. And some of the other outcomes, it's not as noticeable, the difference, although NICU admission was 5.5% higher among cannabis users. Okay, in our third paper that we've looked at so far, we're actually funded from CIHR to look at neurodevelopmental aspects among offspring who had in utero exposure. So we've put together a cohort with born and ICES that encompasses children born in Ontario between April 1st, 2007 and March 31st, 2012. And using the administrative data, we've kind of tracked the kids' access to healthcare up to 2017. So there's follow-up of roughly 10 years using a retrospective design to look at neurodevelopmental outcomes. So I kind of gave you a little bit of a preview on the last slide, but the cohorts are, again, somewhat similar because we use a similar amount of years, but just further back in time. So starting at 2007, we collected births for over a 5-year period until 2012. That's roughly 690,000 pregnancies. We made some exclusions again due to sort of linking between databases. When it is not successful, they have to be removed from the cohort, and some individuals that weren't resident of Ontario or eligible for OHIP couldn't be included in the sample. And because we were looking at childhood outcomes, we removed stillbirth, and also we removed multiple pregnancy and older maternal age births. So the final cohort was a sample size of 508,000. And this is again from born with a link to ICES. And the exposure here is reported cannabis use. We had 3 outcomes that we considered: autism spectrum disorder, and secondary outcomes are intellectual disability, learning disorders, and ADHD. So the incidence of ASD or autism spectrum disorder in the cohort was 4 per 1,000 person years among exposed children, and compared to 2.4 in unexposed. So these are the crude association in the table to the right. So that was a hazard ratio of 1.63. Then compared to our secondary outcomes, which are somewhat more common, so up to 10 per 1,000 person years for intellectual and learning disabilities among exposed children, compared to 4.9 in unexposed, and ADHD is up to 45 per 1,000 person years among exposed compared to 17 in unexposed. So for all the outcomes, the crude associations were fairly large. Again, 1.6 for ASD and over 2 for the secondary outcomes. However, we did some different kind of modeling to try and address potential confounding here as well, including multivariable modeling and using our matching procedure again. The results for autism spectrum, however, remain fairly stable at around 1.5 hazard ratio, whereas the secondary outcomes for intellectual disability, learning disorders, and ADHD attenuated somewhat to sort of just a little bit over 1, and not statistically significant, but kind of in that ballpark. So less clear the kind of signal from the secondary outcomes, although ASD had some effect that persisted in our final model. So some summary of the work so far that we've done. So we're really kind of, as Mark mentioned, interested in this area because cannabis use has been increasing in Canada. I have another paper showing in multiple age groups and demographics, the rates have been increasing, even going back a few years before legalization, including now we're seeing increases in pregnant individuals. So that's brought the work to raise awareness around these trends. In particular, the social patterning of the trends. So we saw the younger women and individuals in particular have higher rates, those of lower socioeconomic status. And our data so far have shown an association with adverse perinatal outcomes, including preterm birth and small size at birth, and some of the secondary outcomes, including placental abruption, stillbirth, and transfer to NICU are also associated. Now we know that these being observational data, there's some potential confounding, and with the social patterning of cannabis use, we have to be cautious, but I think we still are aware that there's an association here that's worth investigating. And now, finally, prenatal cannabis exposure may have some longer term neurodevelopmental implications. So we see some signal in the retrospective cohort analysis that we've done, but we hope to continue to explore that using other data sets. And as Mark mentioned, it's a challenging area for research, just given the exposure and the observational nature of the data. We're dealing with many potential confounding factors and other limitations. So further to the point around what's the take-home message and so why? So prenatal cannabis exposure may have selective deleterious consequences. And I think the parallel with alcohol is quite relevant because some of the effects may not be evident until later in life and maybe lifelong. And like alcohol, this could be creating invisible disability that may not be apparent for some time, and there may be structural and functional impacts. And I think as we learn more, we'll have sort of more evidence to understand what's going on for cannabis. Still have another slide. Yeah, so currently, and this is the most updated statement from the SOGC from 2017, SOGC position statement on cannabis use in pregnancy, recommending that women who are pregnant or contemplating pregnancy should abstain from cannabis use. So I think that's the safest approach at the moment. And we're working right now on a literature review to compile data and recommendations from SOGC and other organizations. And we're going to collect that in our website around resources around cannabis use in pregnancy. Just want to check how we're doing for time. I think we might have time soon to do questions, but we We are involved in a multidisciplinary research program investigating cannabis use and neurodevelopmental outcomes. So I have just 2 slides here. I'll just show about our current progress, and then we can continue. So it's 12:34. Oh, we forgot to do the polls. Yeah, so can we launch one of the polls maybe before we so we did 2 quick polls of the audience. If participants can respond, and we can tabulate the responses. So while we're doing the poll, I'll just say that we're involved in a larger program looking at cannabis and neurodevelopmental outcomes. It includes multiple components, including a comparative analysis with British Columbia and Nova Scotia, looking at the birth registries in those provinces and trying to do a sort of similar analysis as we have in Ontario to understand the patterning of cannabis across the country and association with outcomes. Oh, wow. So they have a review here. So it looks like 75% had agree that all of these aspects are major challenges with cannabis legalization. And should we just go right into the second poll too? And the other kind of area that Mark sort of alluded to is that one challenge in the area of cannabis research, and certainly other substance use, is it's reliant on reporting and disclosure to healthcare providers. So there's been concern, particularly in the scientific literature, that some of the data we have in Born and other databases may be underreported. So to address that, we've launched a sort of an analysis of some stored samples. We have blood and some samples from a few cohorts in Canada that we could actually analyze to look at substance use. And the result of the second poll is coming up. Great. Well, that was very informative. Good response rate. And finally, we are actually, so the third part of this research is to identify and address knowledge gaps. So we're doing some surveys and interviews with pregnant individuals and care providers to understand sort of the impacts of legalization, and understand in a little bit more of a qualitative sense how individuals are getting information. And as Mark mentioned, I mean, anecdotally, we know that the internet and social media is a go-to for many people, and we wanted to sort of explore that a little bit more in some slightly different research. It's not only a database analysis, but using qualitative interviews, and we're doing some analyses of social media posting related to cannabis. And then finally, we hope to launch a longer term sort of cannabis research platform, either a registry of cannabis users, or we're going to do a small cohort in Ottawa that we're going to recruit to and see the feasibility of following individuals over time. And should we do a few questions first, and then we can finish with a video that we prepared on our research?
Yeah, sure. Thank you so much for that excellent presentation so far. I just find this topic absolutely fascinating. And I wasn't allowed to answer the poll, but my personal research questions are about the longer term impacts in children. So that's right. My area of interest. And I found, just to kick off, your adjusted hazard ratio for ASD is really high compared to a lot of other hazard ratios we see, and it remained significant. Did that result surprise you at all?
A little bit, because I was worried, I think, just about confounding and things. So we approached it from a few different ways, including statistical adjustment. We created another sort of like sub cohort with just cannabis users, and if anyone had reported tobacco, for example, or other substances, we removed that individual, and the effect was still persisting. So yeah, I think it's worth to further investigate that association.
Yeah, and the other, secondary outcomes were also quite close to significance. So
Yes.
likely there is something there, right?
Yes.
And, I don't know if either you or Mark can speak to biological mechanism there. Is it just messing with the endocannabinoid system during fetal development?
Possibly. I mean, that's what the literature certainly suggests, that cannabis messes with the, as you say, the endocannabinoid system. It has impacts on central nervous system development, and we've seen the literature in adolescent use of cannabis around psychiatric disorders. So I think there's certainly some evidence mounting around how cannabis can in fact impact neural development, brain chemistry. So yeah, I think like biologically there are some supports for that. I'm always a little bit worried about the observational data, just because I know that there's tons of confounding happening, but having a very robust effect there, it was very interesting, and continue to work on exploring that. So one approach we're taking is trying to replicate a finding in some other studies and cohorts that exist, to see if we can find a similar signal.
Excellent. Daniel, I think we have time to show the video while we wait
Sure.
for people
Yep.
to put questions into the Q&A pod. So
Yes.
go ahead and share your screen, and we can watch that, and I'll give the audience an opportunity to add their questions.
Okay, great. So we produce a video. It's part of the CIHR, the talks, ITSE talks, and we just going to share that here now.
This is Canada, land of maple syrup, Mounties, and cannabis. Yes, cannabis, also known as weed or pot. In the fall of 2018, Canada became the second country in the world to legalize the drug on a national level. Now, Canadians of age can purchase and use cannabis products from authorized retailers. So why does this matter? Early research has shown that when cannabis becomes more widely available, acceptance of its use increases. Currently, over 5 million Canadians use cannabis, including people who are pregnant. When cannabis is used during pregnancy, chemicals can cross the placenta and be absorbed by the growing baby. They can even be delivered to the baby through breast milk. One of the largest research studies to date was completed on over 500,000 mothers and babies born in Ontario. The study found that using cannabis during pregnancy can pose certain risks for the baby, such as babies born early, born at a lower birth weight, or transferred to an intensive care unit after birth. But it doesn't stop there. Other research has shown that babies exposed to cannabis during pregnancy may struggle with concentration, hyperactivity, and aggression during childhood. A lot of people think that using cannabis during pregnancy is a low-risk activity because it is considered a natural substance. The truth is, even though it is legal, we still don't know if or when it might be safe to use cannabis in pregnancy. For now, experts say that it's safest to avoid cannabis products during pregnancy and while breastfeeding until we know more. So why do I care? Because I want my baby brother or sister and all other babies to get the best possible start to a healthy life. Don't you?
Thanks so much. I love that video. And actually, we had two questions about how if the link is available to be shared and how they can get it.
Sure.
Audience get it. So
we can post the link. It's available on YouTube, and I can probably just share the link after.
excellent. So we did have a few questions come in, and the first one is, what is the messaging with regards to breastfeeding, in particular with minimal recreational use?
Mark, I don't know if you can
Sure.
add to that. But
Yeah, so we don't know. I mean, what the concentration of cannabinoids would be. Definitely, that'll be one of the areas of study is looking at exposure and looking at concentration. So, when we don't know, our advice would be to not use cannabis while breastfeeding. It's caused a really interesting debate at the hospital, and what happened is the nurses in the NICU, when they realized that their parents or the mother was using cannabis, didn't want to use the express breast milk. And it became a big heated ethical issue, because overall breast milk is the best, but it created an interesting conflict and conundrum. And again, just with the concern on neurodevelopment, and in the end, I think they did use the breast milk, but there certainly was a lot of discomfort. So I just use the anecdote to raise the sensitivity to the issue in the healthcare community.
right, thank you. And I mean, there's a handful of papers that have sort of shown the concentration levels in breast milk. So it's certainly being looked at. We don't know how much it can actually be absorbed by the baby at that point, but it's definitely present in breast milk.
Thank you. We actually have another question about breastfeeding. So do you have plans to look at the impacts of cannabis on breastfeeding parents as part of your research program? And would it be so helpful to tease out breastfeeding from pregnancy?
Right. No, it's a great, excellent question. I mean, we kind of mentioned at the end, we're just doing some pilot work around recruiting individuals into a cohort study, and one of the areas is collecting breast milk samples. So it'll be a few years before we really kind of get to the question fully, but we're starting to explore if that's feasible to do and collect that data, and then possibly relate it to outcomes. But great question.
The next question is, now that cannabis is legal, do you know if the packaging marketing includes the effects of cannabis in pregnancy? For example, when you buy tobacco, has warnings and pictures all over the package. Just curious, because I wonder if people know about these effects.
Great question. And part of our advocacy is we'd like to see that in the tobacco industry, it makes it very clear that it's not safe in pregnancy. Though we haven't compared them directly, certainly the inference from our work is it's actually much more harmful than cigarette smoking. So that's something that we'd like to work with policymakers federally and to get the message out there.
Great. We have another question. I was curious if there would be any difference in risks based on how the cannabis is consumed, i.e. smoking versus edibles.
Right. So also another kind of evolving area, because I didn't mention in the talk, but typically the major route of use is still smoking. But again, the data that we have is from a few years ago. So as other forms become available, including edibles, we'll have to consider that going forward. But the data don't sort of separate right now. And there's also the idea of having cannabis sort of mixed with tobacco, also smoked, versus using vaporizers and other things. So we haven't really teased out all the methods as of yet, but we're working to do that.
I would actually like to elaborate on that question a bit about measuring exposure of cannabis, which you both mentioned is extremely challenging. But do you have plans within Born or other kind of maybe sub-studies to get at these differences in a more robust way, particularly about quantity and as well, THC? This is another question, but it goes along. THC and CBD.
Right.
Because they're both within the same system, but I think that there's also an extreme thought about the differences and harms between those two.
No, absolutely. And I mean, our approach right now is taking a blood sample to sort of quantify the exposure that way. But and I mean, that has some limitations too. But some other studies are doing things, more surveys, but doing things such as having respondents write down the products that they have, and even weighing some of the joint sizes and things, so we get an idea of how much is consumed. Because I guess maybe some of the surveys around cannabis use are including questions like that, even with pictures to compare like which products they have. But some that's available legally reports THC content, for example, but then individuals can get from different sources, so it can be tricky to measure that.
Yeah, excellent. I just want to invite the audience, if they have any questions, to include them in the Q&A pod. I have another more methodological question. I noticed you had quite a few missing responses on the cannabis question, which is not unusual. But have you done any work on understanding what that population looks like and how it might introduce bias into your sample, into your estimates?
Yeah, it's a good question. So we kind of toyed around with the idea of imputation and things, but then it was a bit unclear about imputing the exposure variables. So we left it as now, but I think it's a good point. The missing data could potentially bias the estimate. So one approach is you could recode the missing as users or non-users and sort of see the effect. But as of now, we haven't fully determined which way the bias would be going.
Mm-hmm. Interesting, because I think I did a rough count. It's like 7% or something. It's not terrible.
It's something about 5 to 10% in that range. Yeah.
So that fits within normal
Right.
ranges of missingness.
So at the moment, the reviewers didn't ding us too much for that, but usually if the missing is kind of in that range, it's considered acceptable. And the trade-off with imputation and things. So because we did matching, and so it was just the sort of computational issues were starting to crop up. So we decided to leave multiple imputation out for now, but it could be a good kind of methodological paper around what bias is introduced because of missing cannabis exposure.
Mm-hmm. Very interesting. And I have one more question about implications, more around, I guess, clinical practice. So this might be for you, Mark. Are you planning on doing some maybe mixed methods or qualitative data gathering about what obstetricians or anyone who takes care of pregnant women are actually counseling at this moment? Because I think for alcohol use, it can be quite variable, despite lots of guidelines from the SOGC. So I was just wondering if that was, if you knew any of that data or if you had planned to collect any of that data.
I don't know of any, but what a great idea. Thank you. Do you want to be a co-author?
Would love to. I find it fascinating, how variable these things can be. And it just, depending on the size of your community as well, how, word spreads, as you say. And, my doctor said this is okay. I hear that all the time from my friends.
Right.
We have one more question here.
Sure.
Is there any data available on use based on race, ethnicity? This may be important given the impact of the social determinants of health.
Right. And another great question. So there are some data on that in Born. It's a little problematic because it's not complete. So again, we get into some missing data issues, but some of our colleagues have begun to use race and ethnicity variables in Born. So it is possible. We haven't done it as of yet, but we're working on improving the data around race and ethnicity, given the importance of that for social determinants.
Yeah, and I just going to add into that Born's done an amazing job at approaching this. There's a race-based data task force that, how do you categorize, how do you get self-reporting in a culturally sensitive and non-traumatic way. So they're putting a lot of thought into it. Like historically, where we had the race-based data was in the prenatal screening because it affects the algorithms and the predictions of Down syndrome. But it was really it was provider for the most part assumption as opposed to self-reported, and it was pretty limited. I think it's Caucasian, Black, Indigenous, and Asian, just like not Southeast Asian, and so 2.0 version will be much more robust, and we're hoping and the vision is to actually have every pregnant woman and person in the province that utilize an app called Omama, which has more in the background and also interfaces with MyChart. So it'll do a couple of things. One, it'll be prompting for best practices during the pregnancy, but also collect and allow a two-way two-way communication. Like now when I do a clinic, because of MyChart, the patients actually have the ultrasound report before I do, because as soon as someone press send, it pops into their MyChart. And the other thing that I'm digressing a little bit here, but I think the value of this is we want to give patients their ultrasound pictures. Like right now, you can't videotape or FaceTime if it's very inconsistent, a little bit like you'd suggested, Sarah, but why can't they have access to see their baby? And it would be so amazing, for photo books. So anyway, that's where we're getting to. But my point in the digression is that was the perfect place to get self-reported information on race, and a self-reporting in culturally appropriate.
Great, thank you. We actually have one more question. I believe we only have time for one more. So I believe tobacco use during pregnancy is known to increase risk of ADHD. Combined use of tobacco and cannabis during pregnancy, I would think would compound that risk. Any thoughts about doing research on both substances in a study?
No, a great point. So we were kind of exploring, so the research today, we're a little bit focused on isolating cannabis risk on its own, but we're also looking now at multiple substance use. So we can certainly consider alcohol, tobacco, cannabis, cocaine, other substances. So obviously, for the research that we presented, we treated it a bit more of a confounder, but I think that's a valid question, and to look at sort of a cumulative effect of multi-substances.
Okay, great. Well, I just want to thank both of you so much again for presenting today. That was really interesting, and to congratulate you on pushing the evidence in this area so much further than we knew even a few years ago. So as we wrap up today's PHO round session, I'd like to thank Daniel and Mark for presenting. I would also like to thank everyone who joined us for today's session. It's great to see such strong virtual participation during such a challenging time for healthcare professionals. To access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Lastly, you can expect to receive the brief and anonymous PHO round survey for today's round session shortly. Please try to complete this to help us improve our programming. Thank you and have a wonderful day.